Amanda Gwee. Amanda is a general paediatrician and infectious diseases physician and clinical pharmacologist at the Royal Children's Hospital in Melbourne. She's also an academic senior lecturer in the Department of Paediatrics at the University of Melbourne. Amanda's research focuses on optimising the dosing of anti-infective agents in children, which is an area of increasing importance in the era of emerging antimicrobial resistance. So I'll cross to you, Amanda, if you want to share your screen.
I think you have to stop sharing for me to do it. Thanks. Can everyone see my screen? Yes?
Yep, we're good.
Okay, all right, great. So thank you for inviting me to speak on the considerations for antimicrobial therapeutic drug monitoring in children. I don't think as a paediatrician I can ever start a talk without saying that children aren't little adults, so they're definitely not, and especially when it comes to antibiotic dosing and pharmacokinetics and therapeutic drug monitoring, there are a variety of factors that we need to consider related to the host, the infection and treatment factors. So really this talk is going to talk about how these factors affect pharmacokinetics and therefore therapeutic drug monitoring. So firstly, in terms of host factors, we know that childhood is a time of rapid organ development, and with changes in end organ function, we have altered drug pharmacokinetics. And also in children, we always worry about the blood-brain barrier and the risk of the drugs penetrating the central nervous system, and also the risk of toxicity. As an ID physician, I'm often asked at what stage can I change patients from IV to oral antibiotics, and one of the things that we most worry about is bioavailability of drugs, because we know that the gastrointestinal system undergoes quite a lot of changes during the early childhood period. And we know that bioavailability is affected by numerous factors such as gastric pH. So when a baby is born, it takes about 24 to 48 hours for them to reach an acidic pH. And then after that, it becomes neutral for about 10 days and then slowly drops to acidic levels at around 2 years of age. And this can affect the bioavailability of penicillin, which is an acid labile drug. So in babies with higher pHs, they tend to have higher peak penicillin concentrations. And with itraconazole, which is weakly basic, they tend to have lower concentrations with a higher pH. But there's numerous other factors that affect bioavailability in kids and newborns. So slower gastric emptying, intestinal motility and permeability, frequent feeding in children under 1, especially when you're giving a medicine that requires the drug to be administered on an empty stomach, and the development of the P-glycoprotein efflux pumps, which reaches adult levels at around 2 years of age. Now, I don't know if any of you saw this systematic review published in 2019. So this was a review of the pharmacokinetics of oral antibiotics in neonates. And I've extracted the bioavailability data, and it included bioavailability data for the aminopenicillins and flucloxacillin. And actually, I found the results fairly surprising in that for the aminopenicillins, the oral compared to IM area under the concentration time curve was comparable to the reported adult bioavailability. But you can see for ampicillin, there was quite a considerable range, but it even ranged up to 94%. And for flucloxacillin, again, the bioavailability was very similar. And at the moment, I'm not sure what the other centres do, but certainly at my centre, we don't feel comfortable changing for invasive infections from IV to oral antibiotics, but these data are promising, and it may suggest that we could consider doing this. I do think we need further data. Even though the neonatal bioavailability data looks promising, we do know that bioavailability of drugs, particularly the azole antifungals, is very variable in children under 12. And here I presented the data for itraconazole, but we've also found these in our studies of voriconazole and posaconazole. But this is a study looking at the 82 children at the Royal Children's Hospital who received 91 courses of itraconazole. And you can see that the dose required in older children more than 12 years of age compared to those under 12 years of age was lower. But you can also see on this forest plot here that there was a wide range of doses required to achieve itraconazole trough concentrations of greater than 0.5. And interestingly, although previous data had shown differences in bioavailability in formulation, our study didn't show that, but that is an important factor that must be considered in children when thinking about the bioavailability of drugs. Other things that change in early childhood is the volume of distribution. So in babies, they tend to have a higher volume of distribution at birth, and that reduces to adult levels at around sort of 6 to 12 months of age. And then similarly for body surface area, the body surface area to weight ratio is higher at birth and decreases gradually to adult levels throughout childhood. Hepatic metabolism is complex, and essentially there are 3 classes of enzymes in the liver, and class 1 includes CYP3A7, and you have highest levels in the fetus and during the first trimester. Class 2, you have constant levels throughout gestation and through to adulthood. And class 3, which represents the majority of enzymes involved in the drugs that we use day to day, it tends to have lower levels at birth, which is about 30 to 60% of adult values, and reaches full activity by 2 years of age. And this can have implications on antibacterial activities, especially for metronidazole, which is metabolized through CYP2A6 into 5 metabolites. And one of these metabolites is responsible for up to 65% of that antibacterial activity. And for itraconazole, it undergoes first pass metabolism through CYP3A4 to an active compound, hydroxyitraconazole. I thought while I'm talking about hepatic metabolism, it'd be important to highlight the nuances with voriconazole elimination. So voriconazole is primarily eliminated through hepatic metabolism through using the cytochrome P450 enzymes, including CYP2C19. And what you can see in that figure is that there's linear elimination at lower doses at around 3 to 4 milligrams per kilo IV twice daily, where for a certain amount of drug, you have a certain amount of drug cleared. But at higher doses above 4 to 8 milligrams per kilo IV twice daily, you have saturation of hepatic metabolism and non-linear elimination. And what this means is that for every small dose increase, you may have quite a large jump in concentrations. And this is why in our clinical practice, when we're hitting sort of the higher end of the dosing range, we only increase by increments of 1 milligram per kilo per day. In terms of renal function, the maturation of the glomerular filtration reaches 50% of adult values at a postmenstrual age of 48 weeks and reaches adult levels at 2 to 3 years. The biggest problem in neonates is that there is no reliable calculator for creatinine clearance in the neonate, and this is problematic for some of the drugs that we would ideally like to dose based on creatinine clearance, such as valganciclovir. And then finally, maturation of the blood-brain barrier. So I think all of us were taught about the blood-brain barrier in children, and you certainly see it written many times in papers. But recently there's been a document from the European Medicines Agency highlighting the controversies around it, which I found really interesting. And I think the main issue with it is that there's been very limited in vivo human data that has shown there's differences in CSF penetration with age. And I thought I'd just highlight 2 studies for you. The first one is a study of age-related changes in plasma to CSF equilibration half-time of acetaminophen. And the equilibration half-time is the time it takes for the concentrations in CSF to be half of the plasma concentrations. So this included 41 kids aged 1 week to 18 years and found no relationship between age and equilibration half-time other than that predicted by the child's size. And if you note that this is a really young population with a median of 12 months. So the other study was a prospective pharmacokinetic study of 20 children aged 4 months to 11 years treated with imipenem cilastatin for a CNS infection. And again, they found no correlation between age or absolute CSF neutrophil count in the CSF penetration. There have been other postulated explanations for why neonates and young children may have higher CSF concentrations. One of the theories may be that neonates have lower total protein concentrations, therefore you have a high free drug in plasma and better CSF penetration. Also, we give a higher milligram per kilo dose, and this may potentially result in higher plasma concentrations. And the other thought is around different formulations, although I think that's less likely. Moving on to infection factors, the things that I think are important to consider is that in children we do treat slightly different pathogens, and secondly that it's really important that we cover CNS infections in young children and neonates with bacteremia. So firstly, different pathogens. The reason why you have to consider what you're treating is obviously because they have different MIC breakpoints. And we know that the pharmacodynamic target of antimicrobials relates to the relationship between concentration and the MIC of the bacteria. And in this table, what I've tried to do is sort of highlight what I think is the unique bacteria that we see more commonly in children. So for vancomycin, we would rarely use vancomycin to treat MRSA in the neonatal or early infant period. But for MRSA, the breakpoint is 2 compared to coagulase negative staphylococci, which is 4. For penicillins, we tend to use that to treat streptococcal groups A, B, C and G infection with a cutoff of 0.25. But in neonates, we use it to treat Listeria monocytogenes, where the breakpoint is higher at 1, and we always need to cover for a CNS infection if the child is septic. Then with Ceftriaxone enterobacterales, the cutoff is 1, Haemophilus is 0.125. But in young children, we treat Kingella kingae, which is exquisitely sensitive, and we could potentially target lower levels. I just wanted to highlight the differences in MRSA and cons for vancomycin in a bit more detail. So I'm sure that you know that for the vancomycin pharmacodynamic target for treating Staph aureus is the ratio of the area under the concentration time curve over a 24-hour period to the MIC of greater than 400. And that's currently recommended in the IDSA guidelines. And this was initially shown in a study from 2004 of adults with Staph aureus lower respiratory tract infections, which showed that the ratio of the AUC to the MIC of greater than 350 was associated with clinical cure, greater than 400 associated with bacteriological cure. And although all patients achieved time greater than MIC target, there was no correlation at all with clinical or bacteriological cure. Similarly, Natasha Holmes and John Turnage and colleagues did a study looking at the vancomycin area under the curve to MIC ratio and 30-day mortality in patients with Staph aureus bacteremia. So this included adults with both MRSA and MSSA bacteremia, and they found that the AUC over MIC target is greater than 373, and it was associated with improved survival in patients with bacteremia. Thinking about young infants and neonates, the most common cause of late onset sepsis is coagulase negative staphylococci, in particular Staph epidermidis. And there's only been one pharmacodynamic study of this bacteria beyond the static time kill studies. So this was a hollow fibre and rabbit in vivo pharmacodynamic model of neonates with central line bloodstream infections, and this study used 2 Staph capitis and 2 Staph epidermidis isolates. And what they found was that vancomycin exhibited concentration-dependent killing, the relationship between peak over MIC, but it also found that near maximal bacterial killing correlated with a ratio of the AUC over MIC of 665 in the hollow fibre model and 520 in the rabbit model. But there's problems with these targets because there's been a recent systematic, or not a recent, but a systematic review published on the risk of nephrotoxicity with associated with different vancomycin AUCs, and they found that an AUC 24 of greater than 650 was associated with increased risk of nephrotoxicity. And then the other problem with this is that for Staph epidermidis, the MIC breakpoint is 4, and if you look at the UCAST MIC distribution data, 61% of isolates have an MIC of 2 and 4. So if we are targeting a ratio of the AUC to MIC within the range of 520 to 665, that's not going to be achievable without increased toxicity, and this definitely requires more study. In terms of the risk of meningitis with bacteremia, there have been previous studies showing that up to 1 in 4 neonates with bacteremia may develop meningitis. And then in children with occult and pneumococcal bacteremia, the rates of coexistent meningitis is about 2 to 5%. But this definitely means that we do need to cover for CNS infection in someone with an unknown CSF. And I just want to give you an example about how this has affected our practice based on the pharmacokinetics of drugs. And I'm using meropenem as an example. So meropenem, this is an RCT comparing conventional versus prolonged infusions of meropenem in neonates with gram-negative late onset sepsis. It included 102 neonates with 51 in each group. And what it found was that with prolonged infusion over 4 hours, the neonates had a higher rate of clinical improvement, a higher rate of microbiologic eradication, and a lower rate of renal impairment. So this trial does show that meropenem infusions are favourable with sepsis, but there were limitations, including that the rate of clinical improvement was low overall, and also they hadn't calculated a sample size before enrolment. But the problem is, this study was published in 2018, and this is a population pharmacokinetic modelling of meropenem concentrations in plasma and CSF. And this was a robust model. It used data from 2 prospective studies that collected plasma meropenem samples as well as opportunistic CSF samples. So in this figure here, what they're doing is simulating the probability of target attainment to achieve a time greater than MIC of greater than 61% in plasma, which is the top 2 panels, and CSF, which is the bottom 2 panels. And you can see that in the left panel, they're looking at bolus dosing, and the right panel looking at continuous infusions. And you can see that with continuous infusions, you improve the probability of target attainment with increasing MICs using a continuous infusion. But what you see in the CSF compartment is you see about a 10% drop in the probability of target attainment due to reduced CNS penetration. This is thought to be due to loss of the concentration gradient. So this has definitely affected our approach to treatment. We definitely wouldn't give an extended or continuous infusion for meropenem in a neonate until we exclude meningitis. And then finally, treatment factors. I just want to highlight how little data we have on which we base our current first-line antibiotic dosing. So in this slide, I've highlighted 5 of the most common antibiotics we use in neonates and children, and I've included Hepatic there because we often use that as our step-down therapy for staph infections. And I've used a traffic light system here where red is no studies, amber is less than 5, and green is 5 or more. And you can see that we still need to do a lot of work in this space, especially because these are antibiotics we use every day in septic children, and it's really important that we know how to use them optimally to try to preserve them. Now, if I were to do the same slide looking at pharmacodynamic data, most of these circles will be red, and that's also another area of need. But other factors to consider in children and neonates would be issues around blood sampling. And I know that in adult centres with aminoglycosides, they do area under the curve monitoring with either 1 or 2 drug levels. And in many paediatric centres, that's still not done, mainly due to concerns around repeated blood sampling and the issues with getting the samples, sometimes requiring sedation and procedural fear and anxiety. But also in neonates who have long lines, it's very hard to blame them back for samples, but also the risk of iatrogenic anemia, not edema. And there was a study of 11 oncology patients aged 1 to 19 years where they took greater than 5% of total blood volume over 3 days, and they saw an average drop in hemoglobin of 2.75 grams per deciliter. And there is a recommendation that you should try to take less than 3 mils per kilo within 24 hours. But you can imagine if you have a very small baby, that's only 9 mils. And if they're requiring frequent blood sampling for other reasons, then it may be difficult to get 2-level AUC monitoring. The other thing I wanted to highlight is that toxicity does differ in children compared to adults, and this may be in part due to the fact that many children aren't on many other medications, and therefore we see fewer drug interactions and less toxicity. And certainly when we did our trial of vancomycin dosing, we randomised 104 babies to either continuous infusions of vancomycin or intermittent dosing, and we found that none of the babies developed nephrotoxicity or Redman syndrome. And then finally, the last thing I want to highlight is that the dosing schedules that we use in neonates and children differ from those in adults. And this is really important when it comes to drugs where your pharmacodynamic target is the area under the concentration time curve. So if you can see in the graph on the left-hand side, that if you give a dose once a day, you can target lower trough levels compared to if you give a dose 3 times a day, and you can target higher trough levels to achieve the same area under the concentration time curve. And in my clinical practice, I've often seen people giving vancomycin to children at 6 hourly, but using the trough targets identified from adult data to achieve an AUC, which is incorrect. What we did was develop a population pharmacokinetic model using vancomycin concentrations that we collected from the patients enrolled in our trial, and developed a 2-compartment model with a sigmoidal maturation model for clearance. And the purpose of this study was really just to provide a way for clinicians who look after neonates to get an idea of what their probability target attainment of achieving an AUC greater than 400 is with different trough concentrations and different dose intervals. So in this figure, we've stratified by postmenstrual age because it is the main predictor of renal clearance, and vancomycin is renally cleared, and then it allows the clinician to then look up their dose interval and determine their probability target attainment.